the transcriptions. Mm-hmm. Mm-hmm. And now I want to tell you about the principles, except the main steps of cavity preparation. You need to know principles of cavity preparation according to Black. Cavity preparation, it is the procedure used to remove demineralized enamel and infected dentine, consists of 4 steps: opening a cavity or removing a poorly fitting restoration, removing infected dentine, evaluating residual tooth tissue, and removing unsupported or structurally compromised enamel, finishing cavity margins. Depending on different classes of dental cavities or of dental caries, you have to remember about these principles of preparation. It's a classic preparation variant, but even if you decide to use modern techniques, you have to remember about these principles of cavity preparation. I'm sorry, something happened with the presentation. I can't change the slide. Please wait a minute. Oh. And we continue. The main steps of preparation. The next steps, it's to clean and dry the preparation using the air water syringe, and examine the preparation and evaluate for proper dimensions. For these aims exist the main dental instruments. You can see it on the screen. It is the dental mirror. It is high-speed handpiece, slow-speed handpiece, dental explorer, dental forceps, and dental probe. It is the main instruments dental, which you will use in your further dental practice in therapeutic dentistry, and not only during therapeutic dental practice. Except the main dental instruments, or you can see on the screen the kit of the burrs for preparation. It is standard kit. Please put your attention on the first burr. It's a very small diameter flame burr used for conservative opening or suspect grooves. The second burr, it's B marked with the marked with B. It is a cylindric burr with rounded head, used for most class 1 and 2 cavity preparation. And the next picture, or the next photo, because it is naturally photo of burrs. It's a carbide rose head burr used for remove infected dentine. The next types of burrs in this kit: and cutting burr used to define and finish its theoretical step in class 2 preparation. The next E, it's a fine-grained flame used for finish class 2 box walls. And F, Arkansas stone used to smooth the cavity margins. And this is standard kit. And if you want to make cavity preparation, you can use this kit of birth. A few words about class 1 standard preparation. You can see on your screen on the slide the form or the shape of the cavity. It is occlusal surface of the first lower molar, and you can see different variant of the shape of the cavity after preparation. It's not a very difficult class for preparation. You can see occlusal surface by your eyes without any additional dental instruments, for example, dental mirror, and without without using any additional methods of dental investigation. The next class, it's class 2. It's a more difficult class for preparation, and it's a more difficult class of cavities. Please put your attention on the screen, and I'll explain you what that means. Outline form. Extent of preparation on two surfaces. Classic preparations are typically later than comparable composite preparations due to material requirements. Basic principles of preparation of caries cavities, second class. Only defective pits and fissures includes all margins on sound tooth structures, marginal ridge conserved. This is marginal ridge. Occlusally convergent buccal and lingual walls, reserve C, curve, and dovetail. This is additional cavity. If you can see the main caries cavity on the approximal surfaces. And class 2 cavities affected even approximal surfaces. The next, what that mean resistance form? Resistance form, it's an internal form of tooth preparation that allows restoration to resist forces of mastication. Pulpal floor, I'll show you, yes, I show you the pulpal floor. Parallel to occlusal surfaces, rounded axiopulpal line angle, adequate depth less than 1.5 millimeter interdentine, occlusally divergent proximal walls. Please wait 1 minute. It's very difficult to change the slides. Convenience form. Form of tooth preparation that allows for physical and visual accessibility to preparation. Proximal contact open with more than 0.5 millimeters of proximal clearance. And what about the preparation, the main sense of preparation? The extent of preparation always depends on clinical and radiographic analysis. You remember that I told you about the first class, that this is withable cavities without using any additional methods of investigation, of the dental investigation. If we tell about the second class, about proximal surfaces, you can meet little difficulties because proximal surfaces, when the patient has adjacent teeth, you can't see without additional instruments. For example, dental mirror, and you can't see without, very often you can't see without using additional radiographic methods of investigation. After clinical and radiographic analysis of the caries lesion, the clinical will shape the cavity based on the extent of the lesion and in keeping with the principle of minimal invasiveness. This chapter This lecture discussed the various levels of tooth preparation according to the type of caries lesion and patient risk level. For the second class, you need, before starting the preparation, you need place a matrix band or metallic fender interproximally to protect the adjacent tooth from iatrogenic damage. Iatrogenic damage means damage after preparations. The preparation because the doctor, the dentist can affect the adjacent tooth, the proximal surface of adjacent tooth. Remove the next step, it's remove unsupported enamel. Remove steps if it appear during preparation. Build the exopalpal line angle. For these aims, you can use the explorer to check the smoothness. Use the probe to check for appropriate depth and depths. Cleaning the final dimensions of the preparations are determined by the extent of the caries lesion or existing faulty restoration. You can position the mirror to achieve indirect visions of the preparation. Place a wedge between the adjacent teeth to separate the contact areas. Orient the burr perpendicular to the lingual surface of the tooth, close to but without touching the adjacent tooth. Position of the burr over the caries lesion or existing faulty restoration. And remember, please, you have to use the carbide burr for dentine preparation, because dentine is not enamel, it's tooth tissue with the with this level of mineralization around 75%, and the structure of the dentine leads to using only carbide burrs for dentine preparation. The next class, please, if you have the questions about the first and the second class, please put these questions. If you don't have the questions, we will continue class 3, standard preparations. You can see the main parts or the main walls after preparation, the cavities according the third class. It's a lingual wall, it's a gingival wall, facial and axial. Axial means cavity floor or pulpal wall. Please, now you can see the thematic cavity class 3 and explaining What that mean? Any part of the cavity after preparation. Gingival contact broken by more than 1 millimeter. And please put your attention that this is intact tooth. Facial depth preserves facial contact and all margins on sound tooth structure. Gingival floor with between 1 and 1.25 millimeters. Incisal floor, you can see. I'll show you this floor. This wall according to incisional margin. We remember that their cavities, the third class after preparation, need to has gingival wall, incisional wall, and two walls, facial and axial. After penetration, the tooth to an initial facial-lingual depth between 1 millimeter or 1.5 millimeter. It's a maximum depth, because you need to remember about the depth of enamel in this zone, in the proximal zone of the incisors. Leave a small enamel shelf interproximally. Break the enamel shell with a hand instrument. Extension should remove the carious lesion of existing and faulty restoration. You can use additional dental instruments such as enamel hatchet. After preparation, use the probe to check for appropriate dimensions and see the gingival length between 2 and 2.5 millimeters, no greater than 3 millimeter, depending on the length of the contact. Gingival floor, between the size of gingival floor must be between 1 and 1.25 millimeters. Incisal floor between 1.25 and 1.5 millimeter. The final preparation dimensions are determined by the extent of the carious lesion or existing faulty restoration. And you have to check for and remove remaining caries or remaining zones of demineralization. Excess of remaining caries using the explorer or spoon excavator. Remove remaining caries to structure using the largest round burr that fits into the preparation with rotary instrument, slow speed, or a spoon excavator. And the clinical note, please listen very attentively. During enamel preparation, we have to use high-speed handpiece. And during dentine preparation, we have to use, or dentists have to use, low-speed handpiece with carbide bore or spoon excavator. And you can, depending on the cavity depth, you can use for preparation of the floor, cavity floor, or pulpal wall. Добрий день. or pulpal floor, you can use only a spoon excavator, because you have to understand that during cavity preparation you can't damage the pulpal chamber. The next, please, if you have the questions, you can put it. Sorry, it's very difficult to change the slides. I don't know what happened. Wait, please. 1 minute. And on this slide, you can see the photo. It is a clinical case. It is a real patient. You can see the photo with the stages or steps of preparation. The caries cavity class 3, direct division. Direct division means you can see the caries cavity on the proximal walls. This is before preparation. The first photo show us the clinical case, caries cavity class 3 before preparation, and the last photo, the same cavity after preparation. On this slide, it is you can see the example of modern techniques of preparation without classical principles of preparation by blacks, because this preparation prepare the cavity for filling by the composite material with a very high level of adhesive. What about class 4? Class 4 preparation. Please put your attention on the slide. You can see the theme of the cavity, caries cavity after preparation, and you can see the main parts or the main walls after cavity preparation. Mesial walls situated on the incisional margin. Lingual wall, pulpal wall, gingival wall, axial wall, and fascial wall. This is the gingival, the lingual surface, lingual. If we tell about lower incisors or canines, and fascial, and facial surface, and palatal surface. We tell about palatal surface if we discuss the upper incisors or canines. For preparation of enamel, you have to use high-speed handpiece. For the preparation of dentine, you have to use spoon excavator or carbide burr. Please put your attention on the pulpal wall. It is difficult structure of the pulpal wall, or the pulpal wall consists from 2 parts. The pulpal wall situated in the incisal surface, and the pulpal wall situated in the proximal surface of the tooth. And the next, class 5. You can see on the first picture the shape of cavity. It is oral surfaces, palatal or lingual surfaces after preparation. And you can see the shape of the cavity, vestibular surface after preparation. Please put your attention on the slide. There are different types or different variants of situation carriers cavity according the 5 class on the black. But this is cavities near the gingival margin. And you have to remember that these cavities have a common features or a common parts of the cavity after preparation. It is gingival wall, 2 proximal walls, pulpal floor or pulpal wall, and upper wall. This is necessary to understand that gingival wall in all 3 variants of the situation carries cavities according class 5 have to be parallel to gingival margin. It is the main feature what you need to remember after during preparation the class 5 cavities. After preparation, there are a few main steps before filling. It is you need to clean and dry the preparation using the air water syringe, examine the preparation and evaluate for proper dimensions. I use the explorer to check for smoothness. I use the probe to check for appropriate depth and width. Clinical note. The final dimensions of the preparation are determined by the extent of the carrier's lesion or existing faulty restoration. Except the classical principles of preparation and classical steps of preparation, exist special cavity preparation techniques or modern preparation techniques. On the last lecture, I told you about modern dentistry. And the main aim of the modern dentistry is to care about natural teeth. What that means care? According the modern technique of preparation and the modern methods of dental treatment, you have to use all manipulations without aggressive, invasive methods of treatment. And special cavity preparation technique means or includes minimal cavity preparation design. Modern dentistry is based on advance and science because dental scientists or dentists, according the clinical data and the clinical investigations, make last few decades make the decision that dentistry, first of all, have to be preventive and have and must care about patients' oral cavity and patients' teeth. During the past few decades, scientific developments in cardiology, dental materials, and diagnostic system have changed dentistry's approach to diagnosis and management of dental caries. Today, it's not necessary to use aggressive methods of preparation, aggressive instruments for preparations, and it's not necessary to use materials without adhesive characteristics. With the development of more of bonding, adhesive, and fluoride-releasing restorative materials like glass, ionomer cement, the concepts of cavity and tooth preparation is undergoing revolutionary changes. In this procedure, retention has not been given much importance because a new classes of modern materials have adhesive characteristic. For example, dental amalgam or classic dental cement has mechanical retention characteristics without any adhesive possibilities. And this conservative approach minimizes the tooth loss and their main attention in dentistry today puts to the early diagnosis. It is the steps of prevention, early diagnosis, and when the dentists can indicate the caries cavity on the early stages of its development, dentists can use minimal aggressive techniques of preparation of the dental cavity. Detection of the caries lesion. You can receive the information, clinical information, and radiographs are usually used to make. Other diagnostic tools are emerging. Some methods are better for detecting occlusal caries, while others are better for detecting proximal or smooth surface lesions. Quantitative laser fluorescence, computed tomography, electrical conductance methods, and tuned aperture computed tomography. There are different methods, new or modern methods of investigation, dental investigation, and please remember that dental investigation includes not only caries detection, because except caries in the oral cavity can exist different pathological processes in the periodontal structures, in the oral mucous structures, and etc. Minimum surgical intervention or cavitated lesion. Значит, minimal MID-utilized techniques or modern cavity preparation techniques and materials to access caries that cannot be remineralized and to restore the tooth with minimal loss of healthy structure. Extension for prevention is over. The Black's main principle of preparation includes extension for prevention, but this is manipulation. It's not necessary if you choose the modern dental material for filling. New preparation techniques. It is air abrasion, hydroabrasion, laser, ultrasonic. Several new tooth preparation and restorative techniques have been advocated. Preservation of natural tooth structure should be guiding factor for the smallest as well as the largest cavity. Cavity preparation design and restorative material selection depend on occlusal load and wear factors. Tunnel techniques for preparation the second class cavities. Proximal only box. I'll show. show you this proximal only box on the slide when we discussed the class 3 preparation. Slot, abrasion, laser, tunnel, accessing the carrier's dentine from the occlusal surface while preserving the marginal side. Slow susceptibility carrier's index, difficulty with the access and visibility, angulation, box only proximal class 2 cavity preparation, except class 3 and class 2 cavity preparation can have this feature. Removing the marginal right by not including the occlusal pits and fissures if caries removal in these areas is not necessary. It is about extension for prevention. Only a small proximal box, slot preparation, and horizontal slot for contact point caries. With the air and hydroabrasion. It is a decay removal and tooth preparation tool that is often used in place of the traditional dental drill. This innovative system allows to conserve more natural tooth structures and reduce the risk of enamel microfracturing. Because the equipment does not produce vibration or heat, patients require little or no anesthetic. It's very important. But in anesthesia, it's very important. But in dental preparation, because caries lesion, when affected the enamel dentine junction and lower, when the caries lesion affected dentine, it's a very painful procedure. Preparation it's a very painful procedure for the patients. But if you want to use air or hydroabrasion, you can use these methods without local anesthesia. They all work essentially by blowing hydra abrasion. You need sprays a conical jet of warm water around the abrasive stream to capture virtually and dust. The warm water, which further improves patient comfort, starts and stops initially with air abrasive flow. Laser, a erbium family laser are less invasive in patients' treatment. They are high-speed than high-speed handpieces. It prevents surface and pulpal temperature rise, tissue cracking, and unnecessary removal of healthy surrounding tissue during cavity preparation, unlike the regular turbine drills. Most generally used lasers, water laser, BLAs. It's produce these types of lasers. You can use ultrasonic cavity preparation and gentle treatment of individual teeth, preserve the tooth substance and protects adjacent teeth. It's very important feature to protect the adjacent teeth when you make the preparation of the carrier's cavities class 2, class 3, and class 4. It's very necessary to remember. And in conclusion, I can tell you that development of new dental restorative material and instruments, extension for preparation to minimally invasive and the goal is preservation of natural tooth structures. It's the main aims for modern dentistry. But from the Black's times, we can use in classic form only classification, topography classification of caries cavities. And for today, I think it's all. After preparation, the main aim of the preparation is to prepare the caries cavities for the filling. Filling, dental filling means anatomy and functional restorations of the tooth, of each tooth, not depending into the frontal zone of tooth, or this is the posterior tooth. You have to restore or or it is restoration of the functional and anatomy features. For these aims, 1 minute, please. For these aims, all dentists use their special types of materials, which called dental materials. All dental materials you have the general characteristics, and you can see it on your screen. Dental materials must not be poisonous or harmful for the body. Dental materials must not be harmful or irritating to the tissue of the oral cavity. Not only the pulp for the gums, for the oral mucose too. Dental materials must help protect the tooth and oral tissue of the oral cavity. Dental materials must resemble the natural dentition as closely as possible so as to be aesthetically pleasing. Dental materials must be easily formed and placed in the mouth to restore natural contours and natural colors. And dental materials must conform and function despite limited access, wet conditions, and poor visibility. It's it's about aesthetic characteristics. What I can tell you about the properties. I'm sorry. The properties, the main properties of dental materials. It is general properties. These properties don't depend on the type of dental material. The first property, it's a mechanical, beating and chewing in the posterior area of the mouth. Examples include force, which in the push or pull on matter, stress, reaction within the material that can cause resorption, and stain, which is any change produced within the material as the result of stress. Means mechanical stress. Thermal change, temperature change in the mouth, which can cause a dental material to contract and expand. Electrical, a galvanic current that can take place with the condition of metals interacting with the saliva. So you remember that saliva, it's a fluid which consists from 99% of water and metal and water can make galvanic effect in the oral cavity. Corrosive reaction within a metal when it comes into contact with corrosive products. Certain foods and beverage can corrode or discolor metals. Solubility, the degree to which a substance will dissolve in a given amount of a wet environment. Please remember the oral cavity with the saliva, it's a wet environment. And application. A material must have specific steps in the application process. The four steps in the process include the flow of materials, retention and adhesion between the dental materials and the tooth, and curing of the material. Uh, Classification of the dental material after the general characteristics of dental materials and the general properties of the dental material, we continue, and now you can see the classification of dental materials. Bases and liners. The subclasses of these dental materials are calcium hydroxide, zinc oxide eugenol, zinc phosphate, class ionomer cement, cavity varnishes, dentine bonding agent. Some words about dental bases and liners. The use of bases and liners is important in dentistry, first of all in pediatric dentistry, and when you prepare the caries lesions with when caries or demoralization affected the dentine with a significant depth. Bases and liners are available to reduce marginal microleakage from the restoration and to prevent sensitivity to their underlying tooth structure. Traditionally, preparation of calcium hydroxide, zinc oxide eugenol, and zinc phosphate were the materials of choice. Presently, glass ionomer cement is also a common base. There are additional type of glass ionomer cement, such as liners, glass ionomer liners, calcium hydroxide cements are supplied in a visible light current system and a two-paste system. You can see this system, two-paste system and light current system of the calcium hydroxide cements. Catalyzed pies containing calcium hydroxide, zinc oxide, and zinc stearide in ethylene tolerant sulfanilamide react with a base containing calcium phosphate, and zinc oxide in glycol salicylate to form an amorphous calcium disilicate. The alkaline pH aids in preventing bacterial invasion. Studies have shown that calcium hydroxide softens under amalgam and resin-based composite restoration. The results are attributed to hydrolysis of the calcium hydroxide by fluid contamination from dentinal tubules as neutralizes occurs occlusal forces, cause gingival displacement of the restoration, leading to displacement and breakdown at the restoration margin. Visible light current calcium hydroxide preparation have demonstrated clinical success and may be less susceptible to hydrolysis. When calcium hydroxide is used, a less soluble high-strength base may be placed to overlay the calcium hydroxide. In conclusion, the calcium hydroxide base or liner have to be covered by another material with less soluble and high straight base characteristics. Characteristics. Zinc oxide eugenol cement contains zinc oxide, rosin, and zinc acetate in the powder. The rosin increases fracture resistance, and the zinc acetate, the effective is accelerating the reaction rate. The liquid is a preparation of eugenol, which reacts with the powder to form an amorphous paste or amorphous halate of zinc eugenolate. The zinc oxide eugenol cements are used to provide sedative effects, but their low comprehensive straight presence clinical limitations. Zinc oxide eugenol paste you can use for example, for the temporary feeling. To straighten the oxide eugenol cements, acrylic resin and aluminum reinforcers have been added. Although these cements are stronger, they remain weaker than zinc phosphide and glass ionomer cement. When evaluated as a base, zinc oxide eugenol demonstrated significant meter leakage in comparison with glass ionomer cement because of their sedative effects and years of clinical success. Zinc oxide eugenol remained the material of choice for the pulp chamber filling material. Following pulpotomies or pulpoectomies in the primary dentition. Zinc oxide eugenol cements should be used with will be used under resin-based composite restoration with limited because the eugenol can inhibit the polymerization of the resin. If you want to use the zinc oxide eugenol cement, such as base or liners under the resin composite permanent filling, you have to cover this cement, for example, by resin composite liners. A glass ionomer cement may be placed over the zinc oxide eugenol too before the placement of resin-based composite to avoid polymerization concerns. The next type of the next types of base it's zinc oxide it's glass it's zinc phosphate. Zinc phosphate cement is composed of zinc oxide and magnesium oxide powder that is mixed with a solution or phosphoric acid and water. The zinc oxide alkaline surface react with the phosphoric acid to form a cement of zinc phosphate surrounding particles of zinc oxide. The addition aluminum and zinc ions buffers the solution to slow the settings reaction, mixing the cement on a cooled slab minimizes heat production during the chemical settings and increases the working time. When using zinc phosphide cement as a base, additional zinc oxide powder is placed in the mixture to thicken it, which increases the strength and decreases the hardening time of the cement. Um, the next type of bases and liners, it's glass ionomer cement. Has become a commonly used base in engine. It has the ability to create a physical-chemical bond to two structure and to release fluoride. Please put your attention that calcium hydroxide, zinc oxide eugenol, and the zinc phosphate have only mechanical types of adhesion or mechanical adhesion. For example, the glass ionomer cement had the chemical type of adhesion and have the highest compatibility for dental structures, for natural dental structures. Glass ionomer cement consists of calcium aluminosilicate glass particles mixed with polyacrylic acid. The initial reaction stage involves the ionization of polyacrylic acid, which leads to a change in the polymer chains from the cold to linear form. The hydrogen ions produced by ionization attack the calcium silicate glass, which also contains fluoride, and causes the release of methyl and fluoride ions. The majority of the metal cations, calcium and aluminium, divalent or trivalent respectively, are bound by the ionized polymer to form cross-linked salt bridges. Calcium and aluminium ions bind to polyacrylic acid at the carboxyl groups, and the gel phase is precipitated to form a matrix of the hydrogen cement. Calcium carboxylates are formed first and a firm gel because of the rapid binding of the calcium to the polyacrylic acid chains. This initial set had the property of being coverable, but in this stage the ionomer is very susceptible to water absorption. Likewise, the free aluminum ions are susceptible to diffusion from contamination and thus are lost from the cement because they are unable to cross-link with the polyacrylic acid chains. Isolation of prepared teeth with a rubber dam is recommended. Aluminum salt bridges are then formed with the polyacrylic acid matrix and the cement hardens. the trivalent aluminum ions ensure a much stronger cross-link than is possible when the calcium divalent bonds alone. The slow reaction of aluminum ions is attributed to the more stringent steric requirements imposed by trivalent ion on a Palladian chain configurations. Glass ionomer can bond to dentine, by free hydrophilic carboxyl groups in the cement, promoting surface wetting to form hydrogen bonds at the tooth interface. At the same time, anionic exchanges occur at the interface with calcium ions being displaced by phosphate ions. Some manufacturers recommended removing the small layer created during cavity preparation and after cavity preparations with polyacrylic acid. This tooth conditioning provides an uncontaminated to surfaces or to surface for bonding. Bonding means between glass ionomer cement and dentine. Tartaric acid is added to the glass ionomer cement to accelerate the rate of hardening without decreasing the working time. Um, Itaconic acid may be placed in glass ionomer mixtures to increase the reactive or reactivity of the polyacrylic acid to the glass and polymaleic acid by be added to modify the reaction. Studies have shown that glass ionomer bases and liners exhibit less marginal microleakage than zinc oxide, eugenol, zinc phosphide, and calcium hydroxide. Thereby preventing bacterial penetration. Fluoride is released from glass ionomer cement by dissolution and diffusion. Glass ionomer bases and liners have demonstrated the inhibition of secondary carriers formation. The fluoride realized it taken up by both the enamel and dentine adjacent to the material. This fluoride aids in creating an inhibition zone that is not susceptible to the demineralization when compared with the areas adjacent to non-fluoride releasing materials. Glass ionomer cement are supplied in anhydrous and hydrous forms. Due to their hydrous form, mixing the cement may be difficult. The anhydrous form has a longer shelf life because the polyacrylic acid is dehydrated and placed in the powder. It is critical that glass ionomer be mixed according to the manufacturer's instruction. If the cement is too thick, the thickness of zinc phosphate cement, uh, it will not provide sufficient water to complete the reaction, and dentine sensitivity may be encountered. The necessary water will be obtained from the dentine, causing sensitivity due to hydraulic pressure created with the dentine. In conclusion, I can tell you that glass ionomer cement, it is the modern class of base and liners due to its properties, very positive properties for dentine and for the tooth, and for positive properties relatively the demineralization which can appear under the liners. in case when you choose zinc oxide eugenol or another type of liners, except calcium hydroxide. Calcium hydroxide has very positive properties for the tooth too, but there is little negative property. It is mechanical adhesion and a low level of the mm, and the low level of sorry, I forgot the word. The word. Okay, so we continue. The low level of density. Calcium hydroxide liners had the mechanical adhesion and low level of the density. The next class of dental materials. Wait 1 minute. It's amalgam. Amalgam resin-based composite, which has subclasses. It is chemically polymerized resin-based composite with visible light polymerized resin-based composite. Resin-based composite where marginal adaptation and formulations. What about, first of all, I'll tell you about amalgam. One minute, please. Amalgam. It is the dental material for the permanent filling. This dental material are widely used in the dental practice, but with this dental material you can feel only posterior teeth due to that amalgam. It's a metal alloy, and the color of the amalgam can't be close to the natural teeth, to the natural color of the teeth. Composition of the amalgam. It is silver, tin, copper, and zinc. Silver gives it straight, tin gives its workability and straight, copper gives it straight and low corrosion, and zinc suppresses oxidation. Precapsulated modern form of amalgam includes modern single use capsule. You can see the single use capsule on your screens. Precapsulated amalgam. Trituration is a process by which the mercury and the alloy powder are mixed together to form the mass of amalgam needed to restore the tooth. The preloaded capsule of amalgam alloy and mercury contains a pestle which aids in the mixing process. Before the capsules is placed in the amalgamator, it is the special it is the special equipment for mixing the amalgam. mass. Many brands require the use of an activator, which breaks the separating membranes. The activated capsule is placed in the amalgamator, and the cover is closed to prevent mercury vapors from escaping during trituration. The amalgamator is set to operate for the length of time specified in the manufacturer's direction. A proper mix should appear free or dry alloy particles and hold together as on unit. It's a more simple variant of mixing amalgam and to put the amalgam filling. But amalgam, it's not that dental material of the first choice. First of all, due to its mechanical type of adhesion, and for the amalgam filling, you can't use the modern preparation techniques. It is the first. The second negative property of amalgam, such as temperature, very high temperature. During the patients take a warm food, for example, or drink warm drinks, and it will be a difference between temperature or temperature coefficient of tooth, natural tooth structure, and amalgam. And first of all, it is absence of aesthetic properties. And but I told you that the amalgam, it's a material widely used in the dental practice. Where before I told you, no, it is the past, except amalgam. Sorry, we have to return to the. Sorry, I forgot to tell you about glass ionomer cement that can use not only such as the bases and liners. Glass ionomer cement can you can use as permanent filling. There are two subclasses of this dental material. It's anterior restoration material, posterior restoration material, and compomers. Compomers, it is the mixing the resin-based composites and the alumosilicate particles, glass. And it will be the new class of dental materials, which will have the positive properties of resin-based composites and classic glass ionomer cements with the chemical type of adhesion to the dental tissues. Compomers are widely used in pediatric dentistry, but you can use this type of material in therapeutic dentistry for adult patients too. Mhm. 1 minute, please. I'm sorry. We continue, and now I'll tell you about resin-based composite. It is the class of universal dental materials. You can use resin-based composite for filling of any class, from the first class to the fifth class of dental cavities, except all positive characteristics. I can tell you that resin-based composite, it is the class of dental materials with the highest aesthetic characteristics. You can imitate all tooth structures and dentine and enamel with helping resin-based composite. For the before the filling the cavities with resin-based composite, I want to tell you about two not two about a few additional materials which you have to use for the best results after filling with using the resin-based composites. It is cavity liners, dentine sealer, dental bases, and etching system. Cavity liners. As their name implies, cavity liners are placed to line the deepest portion of the cavity preparation to provide pulpal protection or dentinal regeneration. The health of the tooth and the type of restorative material selected will determine the type of liner should be placed. The three most commonly placed types of liners are calcium hydroxide. I told you about this type of material, dentin sealer, and in cavity varnish. Dental sealer, also referred to as a primer, is designed to seal the dentine tubules of the tooth, thus preventing oral fluids from seeping in between the tooth and the restoration, which could eventually cause hypersensitivity. Cavity varnish is being used less and less often with amalgam restoration, and dentine sealers are replacing cavity varnish as the liner of choice. Dental bases. When a tooth preparation becomes moderately too deep, a base will be placed before placement the final restoration. For example, resin-based composite. This additional layer helps to protect the pulp. A base can provide the pulpal protection in three ways: as a protective base, as an insulating base, and as a sedative base. And relatively using the resin-based composite, you have to use S etching system. Acid etching, also referred to as a tooth condition, and as is a technique applied to prepare tooth surface before the use of many permanent restorative materials, and first of all resin-based composite. This system was first designed for the preparation of enamel structures for the composite materials and sealants, but research has found the edge in the surface of enamel or dentine. The dental material will have better retention to the tooth surfaces. The main ingredient of etching materials is a phosphoric or maleic acids. This liquid or gel substance is applied to the enamel or dentine surface for a specified period or time to prepare the tooth for the bonding materials. Etching system can apply to the tooth surfaces during 15 or 30 seconds. It's a maximum time for affecting the acids of enamel. And remember, please, that the pulpal wall or pulpal floor of the cavity, dental cavity after preparation can't to be affected by etching system. It's very important to remember. A bonding system. It is the liquid materials that flow into the etched surfaces of a tooth, creating microchemical um, creating microchemical retention. This self-cured or light-cured material improves adherence or adhesive between the tooth and the permanent restoration. Enamel bonding allows the placement of sealants, orthodontic brackets, resin bonding bridges, and bonded veneers. Dentine bonding allows the adhesion of another permanent materials to the edge tooth structure. A major success associated with bonding to dentine is removal of the smear layer, though the etching process. The smear layer is a thin layer of debris that is composed of fluids and tooth components that have remained on the dentine after cavity preparation and that need to be removed. Mm-hmm. Now I'll tell you about composition of composite resins. All types of composite resins have the main components. It's a resin matrix and also known as bis-GMA or bisphenol glycidyl methacrylate, a fluid-like material used to make synthetic resins. Inorganic fillers, quartz, glass, silica, and colorants, which aid to the straight and characteristics necessary for a restorative material. Coupling agent straightens and chemically bonds the filler to the resin matrix. Because resin matrix it is the organic parts of composite materials, inorganic fillers, it's inorganic parts of composite material. And for the bonding of these two types of chemical substances, all composite resins have coupling agents, and pigments give a color for the highest aesthetic. Composite resins. The main characteristics of the composite resins includes I told you that the best density and the best mechanical characteristics, the lowest level of the dissolving in the oral cavity fluids, and the highest aesthetical characteristics. Composite resin is a tooth-colored dental material that is becoming the most widely used material by dentists. And the most requested by patients. Early in its use, this material had a composition that made it aesthetically pleasing, but it was not able withstand some of the properties discussed earlier. Today, this two-colored materials is able to withstand the environments of the oral cavity, be easily shaped to the anatomy of a tooth, match the natural tooth color, and be bonded directly to tooth surfaces for straight. The composition of composite resin includes the resin matrix, inorganic fillings, and decoupling agents. Composite resins are supplied as a paste in light proof of syringes. You can see this paste. I show you this composite resin kit, standard kit. As well as capsules. Composite resins are supplied as a paste in light proof syringes as well as capsules. This material is placed and adapted on the area of the tooth. In the area of the tooth preparation. Once the application process has been completed, the material is polymerized, hardened with the use of a curing light. The exact time of curing depends on the manufacturer's instructions, the thickness of the material, the size of the restoration, and the shade of the material. On the slide, you can see the results after restoration by the composite resin materials. You can see the clinical cases and the photo after. The upper photo means the situation. Before the preparation and filling with composite materials, and the lower photo shows you the result after filling the composite materials. Light curing composite materials, you can see the best results, the best visible aesthetic results. You can't see any differences between natural teeth and between the part of the teeth which will restore by the composite resin materials. And the next photo, it is clinical case of using the composite resin materials for restoration of the posterior teeth. This is the molar. You can see that all anatomical tooth structures you can restore, and you can restore with this material, and all characteristics of resin-based composite materials are close to characteristics of the natural teeth structures. If you have the questions, please put it. If you don't have the questions, thank you for your attention. No questions? Students? No questions?
No.
No, thank you for your attention. Have a nice day. Goodbye.
Thank you.